So many of you may or may not know me, probably don't know me in this room and in this audience, but I'm actually a mom, and I have 5 children. My 3rd child, and my oldest son, Jet, has Duchenne Muscular Dystrophy. He was diagnosed in 2001. And as you all know, because you probably practice in Duchenne or have families that you work with in Duchenne, it is one of the most devastating diagnoses that a mom can get. Well, this mom also happened to be a nurse, and a pretty aggressive nurse. And so I started an organization in 2001 called Jet Foundation. I wanted to build a legacy for my son, but I also wanted to build a village of support around him should something happen to him. But my mission, as every mom's mission is to save his life. Well, Jet grew, and as he grew, he progressed, and he declined in his disease. And about 4 years ago, I heard about a drug in a clinical trial. It was called Eteplirsen, and it was run by a company called Sarepta Therapeutics. And I happened to live in the Boston area, so Cambridge wasn't that far. And so if it meant that I showed up every day at that office to find out how we could get access to that drug, then I showed up every day at that office to find out how we could get access to that drug. And 2 years ago, almost 2 years to the day today, Jet was actually included in a safety study at the age of 19 for Eteplirsen. I can stand here today and tell you that the reason why it was so important for me to go out and find you at the coffee bar, to find you at your booth, to find you wherever you were, is because I know I have living proof, living in my home today, that one clinical trial changed the course of this child's disease. My son's life was saved. He was going to die. His ejection fraction was declining. His PFTs and FVCs were also declining. He's now stable. He's actually regained some strength back. And at 21 years old, his 3rd year in college, which we are so proud that he can do this, he can go to a party and he can open his own beer. He can also drink it. So there are good things and there are bad things, but you know what? At 21, to have somebody open your beer is a good thing. So he's actually living life. And so it's very important to me to get out into the community to educate neurologists, physical therapists, other nurses like myself, and other parents with education. What I found is that not everybody knows about the trials that are out there. And if there's a trial that can save a child's life, then you need to know about it, and you need to help enroll that family or that child or help them come to that decision. So that's why we're here today. So I'd like to introduce Dr. Jean Mah, and we are very fortunate to have Dr. Mah here. She's going to give the presentation today, and then hopefully there'll be some time for questions and answers. We have some industry reps in the room as well. So if you hear about a trial that's interesting to you, please feel free to ask the question. Dr. Mah is a pediatric neurologist and the director of the Pediatric Neuromuscular Program at the Alberta Children's Hospital in Calgary, Alberta, Canada. She's an associate professor in the Department of Pediatrics and Clinical Neurosciences at the Cummings School of Medicine, University of Calgary. Dr. Mah is currently involved in a number of collaborative research studies related to pediatric neuromuscular diseases, including natural history and the treatment trials for Duchenne. So I'd like to introduce Dr. Mah and thank her for being our guest today and our speaker.
Would you like to join me up here?
Thank you.
Okay. Thank you very much, Christine. And her team has provided all the resources and support to make this event happening today. And I welcome and thank you all for being here. It's a pleasure for me to speak about this explosive field of emerging new treatment for Duchenne. And I hope that this information will help you and give you further ideas and references to move forward together. I have a few disclosures. I have done consulting work for a couple of companies, and I'm also a site clinical trial investigator for new investigatory drugs, including the list here, and I'm also a member of the Cooperative International Neuromuscular Research Group. So this is familiar to all of you. Duchenne muscular dystrophy is a genetic muscle disease, and it affects 1 in 3,500 to 5,000 live birth males. It is the most common form of muscular dystrophy of childhood. So for this reason, this morning, I'm going to take time to review with you the key clinical features as well as pathogenesis of Duchenne. I'm going to discuss the importance of genetic diagnosis in this era of new emerging treatment. And I will give you the landscape of what we have now and the upcoming clinical trials for this genetic disorder. So this is a slide and provide a historical perspective. Duchenne in 1861 described a young boy with a condition that he named hypertrophic congenital paralysis. And he noted this striking feature of muscular overdevelopment or hypertrophy, especially in the calves. And in his case report, he stated the following. It appears that the pathological lesion that caused the paralysis also induced the athletic development of powerless muscle. So this is one of the paradoxes that we see in Duchenne, and sometimes it could be falsely reassuring to clinicians, as well as sometimes families, because of the very bulky muscles that may sometimes mask the weakness that is progressive. And in the next slide, Dr. Gowers in 1879 put together a seminal monogram regarding this condition, which back then still bears the name of a hypertrophic muscular paralysis. Although he was not the first to describe the maneuver of affected young boys to get up from sitting from the floor to a standing state using the maneuver here of getting on all four, pushing up from the floor, and eventually using the hands to climb on the legs in order to stand upright. His clear illustration of this phenomenon it's really one of the landmark papers for describing muscular dystrophies, and this maneuver is still being recognized right now as one of the clinical signs of neuromuscular weakness affecting the proximal muscles, and is known as we all know, the Gowers sign. So here, summarize for you the symptoms or presenting complaints of boys affected with Duchenne. The parents will notice a developmental issue early on, predominantly motor, but other domains of development may be affected, including speech, learning difficulties, as well as cognitive impairment to a variable degree. And when you look at these boys, you will, as the authors in the past have described, the muscular hypertrophy, including large calves, the presence of progressive joint contractures, as well as proximal, and then distal, and then generalized muscular weakness. And the disorder is characterized by very, very high muscle enzymes measured by serum CK in the blood, indicative of ongoing muscle damage. And as Christine has alluded to as a personal family experience, that Duchenne is a progressive genetic muscle disease. Besides the presentation of developmental delay, it leads to progressive impairment in mobility, at first with walking, climbing stairs, getting up, and so forth. But over time, we also see, unfortunately, the development of cardiomyopathy, respiratory insufficiency, orthopedic complications such as scoliosis and other skeletal deformities, and then followed by the decline of upper limb function, then ongoing need for respiratory support, and premature death, usually before the third or fourth decade of life because of cardiorespiratory complications. The next slide basically summarizes the issue with Duchenne pathogenesis, and one can say that it is an obvious imbalance with ongoing muscle damage and failure of repair. So as you all know, the DMD gene located on the X chromosome is one of the largest genes of the human genome. It's comprised of 79 encoding regions, or known as exons, including the actin binding domain in the N-terminus, 24 spectrin-like repeats in the central rod domain, a cysteine-rich dystroglycan binding site, and then the C-terminal domain. The extremely large size of the DMD gene is responsible for the complex mutational spectrum, as well as a high spontaneous mutation rate, as high as 1/3 of families may not have any family history of this genetic muscle disease. And you are not supposed to read it, but it is true that, it's very variable from just someone complaining of cramps, muscle pain with exercise, to the severe Duchenne, which is the focus of this talk, as well as a milder but much more variable phenotype known as Becker muscular dystrophy. So the next slide talks about how the DMD mutation and where does it exert its effect. Dystrophin, as shown in this slide in here, is interaction and is part of the dystrophin-associated glycoprotein complex. Here is its binding site with actin, thin filament, and it is associated with the dystroglycan here, as you can see, and sarcoglycans, and a whole bunch of other essential sarcolemma proteins that maintains the function of muscle, both from a structural as well as other processes that are essential for well-being of the muscle cell. And a mutation disrupts this. Loss of a functional dystrophin disrupt this glycoprotein complex. And the cascade that follows here basically tells us that when you have instability of the structure, then you have fragility of the membrane, which leads to unregulated influx of calcium, and then that leads to release of proteases and inflammatory cytokines, among which are the tumor necrosis factor alpha, the nuclear factor kappa B, and further on contributing to fibrosis. At the same time, because of the displacement of the neuronal nitric oxide synthase, then there is dysfunction of blood flow, leading to relative ischemia, and the reparative process, including the AKT P13 pathway, is also being inhibited, and then that leads to reparative failure. So pathologically, we can see this process happening. In boys with Duchenne, the muscle is right from the get-go abnormal, and progressively it becomes replaced by scar tissues as well as fatty tissue. And the variation of fiber size increases over time, and consistent with the dystrophic process, there is muscle necrosis as well as attempts at regeneration, which is unfortunately not successful. Immunostaining for dystrophin, this is the control here, shows usually absence or severely reduced expression of dystrophin, except for the occasional revertant fibers. So the severe Duchenne phenotype that we see can be explained by Dr. Monaco et al. In regards to this reading frame hypothesis. The Duchenne phenotype is usually the result of an out-of-frame mutation. In this example, we used deletion, but as I'll explain, there are other mechanisms. So there's a genetic mutation causing a deletion. The deletion leads to an out-of-frame mutation that leads to a truncated protein, and that is rapidly being cleared, and the loss of protein results in Duchenne. Now, in-frame mutation is different. It is still a mutation. However, because of the truncated protein with preservation of a shortened protein chain, somehow it leads to a variable and somewhat milder phenotype that is known as Becker muscular dystrophy. The exception to the reading frame does occur in approximately 10% of DMD mutations. So this next slide summarizes what we know about the proportion of mutations that we see in dystrophinopathies. 2/3 of them in here is the result of one or more exon deletions, and 10% is related to duplication of the DMD gene, and another 25% is related to other types of mutations, including point mutations leading to stop codons, small deletions, and other splicing mutations that are present. So in order to help make the proper diagnosis, to give the right prognosis, and to confer individualized treatment therapy, it is very paramount for us as clinicians to recognize the clinical features of Duchenne, to send for the first screening, which is the testing of the muscle enzyme or serum CK, and then followed by molecular genetic confirmation. Genetic tests usually in this time involve the assays that which examine all 79 exons of the dystrophin gene and their methods such as multiplex ligation probe amplification or comparative genomic hybridization array to look at that in detail, which can identify a pathologic deletion or duplication in about 70% of the time. In cases where the initial genetic testing was negative, and the next logical step then is the whole dystrophin gene sequencing to help to make the diagnosis. Less common now, muscle biopsy can be helpful, not only in identifying the lack of dystrophin on immunostaining, but it can also help to provide complementary or RNA, which can then be used to identify the DNA and the precise mutational event. Now, if you have patients who had the initial genetic testing being negative and are not approved for funding for further genetic testing, there is help. With the support of Decode Duchenne from Parent Project and Duchenne Connect, Duchenne boys and young men can get free genetic testing if they are eligible, and that includes both Canada and United States, and then to receive proper genetic counseling. And of course, the genetic report then can help them to identify specific treatments. So this is very helpful resources, and we are grateful for the support of the industry sponsor for making this happen. So I'm going to move on the next half of my talk focusing on the recent scientific advances that has helped us now to identify new emerging treatment strategies for Duchenne. And the regular updated information is available through the clinicaltrial.gov website. And I am very pleased that every time I go there, I find new studies and new upcoming potential treatment for Duchenne. So this is a worthwhile website to know about. And this is my home site at the Children's Hospital in Calgary. So this is a very exciting slide. We all know that maybe more than a decade ago, this slide was very sparse. But look at now the therapies that are in development, and I like it. I'm grateful for Ann Lucas for allowing me to use this slide. Basically, the key strategies for treating Duchenne's are as follows. We can focus on dystrophin restoration and replacement, and the strategies there includes exon skipping, gene therapy, stop codon read-through, as well as the excitement regarding CRISPR or gene editing to come. There are also a number of strategies that are important for helping muscle growth, repair, and protection. And the therapies examples there including myostatin inhibition, follistatin, which is a muscle growth stimulating protein, upregulation via gene therapy as well as other modalities, selective androgen receptor modulation, and this very important, very similar protein to dystrophin known as utrophin. We need to combat against the ongoing inflammation and fibrosis, and so we have steroids, steroid analog, as well as antifibrotics. And we talked about the calcium being a big mediator of muscle damage, so there are drugs that promote calcium homeostasis, and the ryanodine receptor complex drugs. And knowing that cardiorespiratory complications are the major cause of mortality, there are new drugs, new therapies, including cardiac stem cells, and also upcoming trials to look at traditional drugs to determine the best therapies, blood flow with NOS upregulation, and then mitochondria. The dysfunction of mitochondria is what ultimately causes cell death. So there are a lot of new exciting therapies for biogenesis as well as enhancement of mitochondria. So this next slide start off with then that corner that I showed you about dystrophin restoration and replacement, and the two major fields that are currently in progress. It relates to exon skipping as well as stop codon read-through. And I will go through a little bit detail about the current exon skipping trial, including the confirmatory trial of eteplirsen or Exondys 51 for exon 51, and then phase 3 double-blind trials for exon 45 and 53. And NS Pharma is also doing a phase 2 trial for exon 53, and the Lechis Senko is doing phase 1 and phase 2 trial for exon 45. So let's talk a little bit about exon skipping. The idea of exon skipping, and using the example of a deletion here of exon 48 and 50 is missing. So the idea of exon skipping is using antisense oligonucleotide to cause a specific exon skipping. In this case, is exon 51 that is being skipped in pre-messenger RNA splicing. And so then, as a result of skipping it, then now you have 47 juxtaposed to 52, and this convert to an out-of-frame to now an in-frame mutation, leading to the production of a modified truncated protein that we saw before earlier in Becker muscular dystrophy. And just briefly here to show the long-term data of eteplirsen, which initially was a double-blind study, now is now more than 3 years longitudinal data, to show how for the boys with confirmed mutation related that is amenable to exon 51, we see this very encouraging results in the majority of the boys, showing improvement in the gait stabilization of their motor function, as well as the evidence of increased dystrophin expression in muscle biopsy and restoration of the dystrophin glycoprotein complex. And so for this reason, compared to historical control, it's clinically significant. As of September 19, 2016, Sarepta Therapeutics has received accelerated approval for eteplirsen, also known as Exondys 51, for boys with DMD that are amenable to exon 51 skipping. Now, part of this accelerated approval require ongoing confirmatory clinical trials, I explained, and also to demonstrate a clinical efficacy using the North Star Ambulation Status Test. So, As you can see here, that was only one example of exon 51. There are a number of other exons, and a lot of them focus on what we call the mutational hotspots involving the area of the dystrophin gene between exon 45 to 55. And exon 51 comprised 13%. We have other exons, 53, 8%, 45, 8%, and so forth and so on. And if you can just appreciate in this pie here that the majority, almost up to 80%, could be amenable to exon skipping as potential disease-modifying treatment, as outlined here by Dr. Artsman's Russ paper several years ago. And the next slide is not meant for your memorization. It just highlights how complex it is that you see for exon 51 on your left side here, that there are a number of mutations that is amenable to exon 51 skipping, as an example. And so this highlights two things. One, we need precise genetic diagnosis in order for affected boys to benefit from these individualized treatment. And two, it is too much for us to remember, and so we need resources. And I'm grateful for Jet Foundation for putting this together in their website, as well as other sources. If you have questions, please approach your colleagues to find out if your patients with the certain genetic mutations could be amenable to exon skipping, for example, as well as other emerging therapies. So this is really just to highlight those two key points. So the next therapies I want to briefly highlight is stop codon or nonsense mutation read-through. And stop codons are the result of point mutations, and it accounts for about 13 to 15% of Duchenne phenotype. And so what basically happened is that it caused the abnormal or early presence of amino acid nucleotides that causes abrupt arrest of further protein translation. And as a result, then no more protein is being assembled, and then again is degraded by nonsense-mediated decay process. So the stop codon works by following mechanism. It basically binds to RNA, and the stop codon medication, in this case ataluren, allows for the protein synthesis by making it difficult for the translation process, to recognize this premature stop codon, and then as a result you have a modified protein, and then that helps to improve function. And in the earlier clinical phase 2b trial of ataluren in 174 boys in a double-blind placebo-controlled study, the use of ataluren at 40 milligram per kilo, so highlight here in yellow the low dose, after 48 treatment led to a marginally significant improvement in the primary outcome, which was defined then by the 6-minute walk distance, compared to placebo or those on high dose. And the high dose therapy did not show the clinical improvement. That's because of the inherent bell-shaped response curve of the ataluren drug itself. And on the basis of this result, ataluren, now also known as Translarna, has received conditional approval by the European Medicine Agency as indicated treatment for boys with Duchenne Muscular Dystrophy secondary to premature stop codon mutations. So moving now to this gene therapies, and the whole idea is to use a well and tested viral vector to bring on to a muscle cells the need for protein molecules that can help improve the function. It's despite the known genetic mutations. So they are all inclusive of DMD mutation and is not dependent on the specific type of mutations. So ongoing trials, phase 1 and phase 2 includes follistatin, which I mentioned to you before is a muscle growth stimulating protein. GAL-GT2 is a glycosyltransferase, and it is important because when you upregulate it, increase alpha-dystroglycan glycosylation, and it also increase and modulate the expression of dystrophin as well as utrophin. And then, of course, the dream is to be able to restore dystrophin expression, but because the dystrophin gene is so big that we need to take out part of that rod domain and the assembly into smaller so-called mini or microdystrophin, and several trials are in process, including phase 1, done coordinated through the Nationwide Children's Hospital, and there are other work that are being in preclinical phase right now. So the simple concept here is, so you have a gene. In this case, the example is a microdystrophin. You have a known, safe, well-tested viral vector. In this case, is the adeno-associated virus 8. And it then goes and recognizes only very specific muscle promoter. And then it goes in to each individual nuclei, and then it leads to then the expression, in this case, the microdystrophin on the sarcolemma. But it could also be increased expression of follistatin, utrophin, and so forth, and the GAL-T2 transferase. So this is the principle here. Next strategy has to do with cell-based therapies, and I have highlighted the ongoing work, including Dr. Tremblay and his team at the University Center Hospital in Quebec of myoblast transplant using allogeneic donor cells, and they are injecting to the local muscle in the forearm, the extensor carpi ulnaris, similar to other gene therapies. They are working at focal injections currently. And this next study, cardiac stem cells using cardiosphere-derived cells, is the focus of hope to halt the progression of cardiomyopathy by Capricor Therapeutics. And they're both in phase 1, phase 2 trials. And Dr. Palangario at the University of Minnesota is trying to use skin fibroblasts to induce them back into stem cells, the iPS stem cells, as a potential treatment option for Duchenne, and is currently in the preclinical phase. The next slide just summarizes the potential source of stem cells. And even though this was an older paper and the focus of ischemic heart disease, I thought it was very nice to include it because there are ongoing stem cell studies for Duchenne, including circulating stem cells, myoblast that I talked about, bone marrow-derived stem cells, this resident cardiac stem cells called cardiosphere that you can kind of collect, biopsy from muscle, biopsy from skin to induce iPS, and embryonic stem cells. And in this example, it is interesting because you can then infuse, in case of cardiac myocytes, you can infuse these stem cells directly in the coronary artery, which is the focus of the Capricor study, or one can inject it directly into the muscle as we do with gene therapies, as well as the myoblast transplant therapies. So looking at how can we help muscle grow, to repair, and to continue to do well. There are some new exciting molecules, including utrophin modulator. Summit Therapeutics has their small molecule oral bioavailable to help increase utrophin expression. It targets the utrophin A promoter. It's also known as ezutrmid and is currently in phase 2 trial. And upregulation of other compensatory cytoskeletal proteins such as biglycan, lemon, integrin, and sarcospan kind of follow the same possibility of upholding the integrity of the sarcolemma and compensate for the lack of dystrophin. Akashi Therapeutic is working on selective androgen receptor modulator. The principle is to have a drug that resembles the anabolic steroids but without the side effects of it. And so it's right now in phase 1. And then the exciting work with myostatin inhibitor, and we currently have a couple of clinical trials related to PF06252616, also better known as domoagrozumab. And Bristol Myers Squibb has 96089, and the Pfizer drug is currently in phase 2, and BMS is in phase 1 and 2 clinical trial. So this next slide just tells you that utrophin and dystrophin are very similar. Utrophin is expressed in the developing and regenerating fibers, but it is being turned off in mature fiber and replaced by dystrophin. So this is the normal fibers. And in early phase in DMD, utrophin is being expressed in attempt to regenerate, but because you don't have dystrophin, then you have muscle degeneration. And in the case of utrophin modulation, you can see how in the beginning you have utrophin, and if you can modulate and increase its expression, then it is hoping to compensate for the lack of the dystrophin. And then this next slide talk about myostatin inhibition. So myostatin is a negative regulator of muscle growth. So basically, the nature experiment when you have mutation of the myostatin gene, as well as the therapeutic strategies to kind of inhibit myostatin leads to super mouse, a much bigger mass compared to the normal mini mouse here. And elegant experiments shown here in the marine model, the MDX mouse, more than a decade ago has shown how knockout of myostatin in the MDX marine model improves the muscle phenotype here. And then in another experiment, inhibition or blockade of myostatin help. This is the control MDX mouse. This is the treated animals compared to wild type help to normalize the CK, and you can also see a restoration of the dystrophic to improvement in the muscle pathology. So these are two very exciting studies that are ongoing. Now, anti-inflammatory agents have their role, as I explained earlier. And there are a number of strategies. Bifibrogen is monoclonal antibodies against FGs, against the connective tissue growth factor. And connective tissue growth factor is partly responsible for the fibrosis and muscle degeneration. So elegant experiments have shown that if you can inhibit it, then you can actually help to partly restore and allow muscle cells to regenerate. And so fibrogen is currently in phase 2 trials. We have a product by Catabasis, CAT1004. It does allosonamet. It's quite a long name. I mean, it's just really exciting work coming up in phase 2 trial because it is also capable of inhibiting the NF-kappa B and help to induce myogenesis and other reparative process in place. Givinostat. So this is an HDAC or histone deacetylase inhibitor by Italfranco company, and they're going into phase 3 trial hopefully early next year. The histone deacetylase inhibitor not only does it help to upregulate myogenesis and promote muscle regeneration, it is also a powerful anti-inflammatory drug. So it has a promise of combining a few mechanisms that can potentially help modulate the disease. And of course, we have prednisone and deflazacort that is being compared head-to-head as part of the 4DMD trial coordinated through the University of Rochester and Newcastle. England, and a steroid analog. Vamorolone is a steroid alternative that's a designer drug for Duchenne Muscular Dystrophy by Reveragen Pharma, and are now recruiting for phase 2. So as this slide shows as a reminder that NF-kappa B plays a central role in disease pathogenesis. It is responsible for inhibiting muscle regeneration, inducing inflammation and fibrosis, and causing muscle degeneration. So targeted therapies, such as the anti-inflammatory drugs seen in the previous slide, will help. And this process is in place very early on, even in infants with DMD, and any kind of mechanical stress will activate this NF-kappa B, and so that's why it is an important therapeutic target for us. And corticosteroids, so until we have therapies that are more promising, prednisone and deflazacort remain the standard of care and is highly endorsed, including the most recent Academy of Neurology, as well as the previous DMD guidelines. New guidelines will be forthcoming, but you can see that deflazacort really is the derivative of prednisone, very similar, and they have a number of potential mode of actions that are helpful in Duchenne, but they also have appreciable side effects. So we are looking forward to this head-to-head comparison to determine which of the two drugs are better for Duchenne in the 4DMD trial. Historically, in the natural history study, we do see, and this synergy coordinated study headed by Dr. Craig McDonald does show that steroids impact loss of ambulation. Comparing untreated in red and treated for at least 1 year, it does enable the prolongation of independent ambulation. And this is historical data only, so it's hard to say, but one could imagine that there could possibly be a difference between deflazacort and prednisone, but these are natural history studies, and you cannot really say for sure that there is a difference. To quickly mention other pharmacological therapies here, we have the problem with calcium dysregulation in Duchenne, so a number of drugs, including Ramipril is a sodium type 1 inhibitor drug, which is now in phase 1 trial. And there are 210 RILCALs to act on the ryanodine receptor complex, and then Akashi Therapeutics with their preclinical work in the stretch-activated calcium channels. A whole bunch of cardiac drugs, beta blocker, the aldosterone inhibitor, including spriromolactone and eplerenone. They are in phase 3, phase 4 trial, as well as the long-standing kind of comparison between ACE inhibitor and beta blocker. Which one is better? So they're all part of the phase 3, phase 4 clinical trial. And of course, for respiratory therapy, we heard about idebenone, now known as Rexon, sponsored by Santhera Therapeutics, as showing a clinically significant benefit for boys and young men with Duchenne that are not receiving concurrent corticosteroids. So there's an upcoming phase 3 trial of this drug for those who are now on steroids for at least a year. So these are other therapies. And this is to remind you that besides corticosteroids, cardiac medications, there are a whole host of supportive strategies, orthopedics, physiotherapy, occupational therapy, and so on. That's part of the standard of care. And we anticipate there will be a revised new standard of care document coming up soon that outlines all these new emerging paradigms for Duchenne. So do look out for it over this coming year or so. And this is just part of the standard of care currently, cardiac assessment every 1 to 2 years and every year after at the age of 10 and onwards. And this demonstrates the progression in cardiomyopathy, especially with the left ventricular dilatation and systolic dysfunction here. Pulmonary care, it's standard, and increasingly we are training boys to do pulmonary function early, even before the age of 6. And when they have symptoms or the age appropriate, near the kind of turn into preteen years, sleep studies, and there are a number of strategies in addition to pharmacological therapies, including breath stacking technique, cough assist, and positive pressure ventilation as shown here. And these supportive strategies are mostly responsible now for a boy with DMD today can look forward to living beyond the 4th decade of life. So this is important to know. And this is an example of a lung volume recruitment. There's a StatFast study headed by Dr. Sherry Katz at the University of Ottawa Children's Hospital, Shield. And it shows how using a modified resuscitation bag, breath stacking, increase the air, the lung compliance, help to move secretions better by having a much more forceful cough. And so that's part of a clinical trial. And bone health exercise programs are important. These are things that we are aware of, and that there is a like bisphosphonate zoledronic acid for children with a host of disorder, including Duchenne with osteoporosis. And there are also a couple of very elegant, one using whole body vibration therapy, and another one at the University of Florida looking at an isometric exercise program to help boys with Duchenne to test that they're safe and that it could actually help promote function and wellness. So I have summarized to you the following, the key clinical features of Duchenne using historical perspective of Duchenne and Gowers. I think it is important to recognize them as early as possible. The pathogenesis of Duchenne is complex, as you can appreciate, and so multiple targets may need to work together in order to make the best possible outcome. New therapies are emerging. It is important for boys and young men with Duchenne to have precise genetic diagnosis in order to be able to benefit from them. And standard of care in collaboration with families, clinicians, specialists, researchers, as well as industry is the key to improving standard of care and outcome for this lovely group of young men and boys affected by this horrible disease. There are a number of resources here that I list for your reference, including Decode Duchenne through the Duchenne Connect organization, various work group and resources for upcoming trial. And I thank again Christine and your team, Jet Foundation, for allowing us to speak on this very important topic today. So thank you very much for coming, and I look forward to talking to you afterwards. Please let us know if you have any questions or comments. Okay.
Thank you. Does anyone have any questions?
Yes. First of all, that was an incredible talk. Very, very nice. Thank you.
Thank you.
In the use of steroids in these children, do you like to use prednisone on a daily basis, or do you like to pulse it weekly? And also, how early can you look at starting children, with Duchenne's on steroids? So we have a recent diagnosis of an 8-month-old with Duchenne's. And so the question is, how early can you implement therapy, in Duchenne?
Excellent question. Thank you for your comments. I have a very good colleague, Dr. Ann Connolly at WashU, St. Louis, and she and her team are heading this precise kind of using historical control to look at weekly high-dose steroids as a potential treatment. Now, the 4DMD trial looks at daily prednisone, daily deflazacort, as well as 10-day on, 10-day off prednisone. These are all part of an ongoing clinical trial. And can you start a boy 8 months with? That's pretty hard. I would love to know what his mutations are, because there may be some other options. And, I think that the short answer is we don't know. I do think historically from natural history that daily dose therapy seems to make sense. In Europe, our colleagues are starting boys as young as age 2. So depending on the mutation, there may be a role for you to discuss, and do consult, reach out to these experts in the field to say, what could we do best for this 8-month-old, and to make sure that he will benefit from whatever options that are out there. Does that help?
Yeah, so he has a 40, I think a 48 through 50.
Oh.
So he's going to be a candidate for Sarepta.
Yeah, very interesting.
Make sure you have the microphone so we can hear
Yeah,
that.
can you guys hear okay? Do we need to pass the... Yeah, so that's interesting. Very good thought. Yeah.
Yeah,
So
we're looking into that and hopefully get that started sometime.
yeah, amazing. Hey,
So
Dr.
I'll
DeCruz,
second what
my mentor. I am so glad to have Dr. Greenwood and Dr. DeCruz here, who trained me, taught me everything I know about neurology.
Well, I don't know how well I trained you, but I know Bob must have done a good job because you're doing really well, Gene. And I'll second what Vinay said. There was an elegant and comprehensive review of this whole complex field. I have a two-part question. Given all of this interest and all of these options that we have for clinical trials, are we at the point where we should consider evaluating eligibility in clinical trials as standard of care now? I mean, this is a great opportunity and option for us in this field after all these years and decades of not having options to have this whole set of options to come from. So do you think we're close enough to considering that, as even though it may not be codified yet, that we should, in our practices, consider this as a given?
Most definitely. I don't have time to talk about it, but we have now Duchenne registries. In Canada, we have the Canadian Neuromuscular Disease registries. For me as a clinician in Calgary, every new child, the first line in my dictation is so-and-so has this mutation. It's always a reminder and then how the boy does, are they early stage, what stage of the disease? The hope is, and I think that this is the goal is for every child to be offered potential to participate in a clinical trial and at any one time. And then if they fail, go look for another one. If they've done so and finished in one study, can they move on to another? Because my personal experience, again, seeing boys with Duchenne walking past their 16th birthday, this is very meaningful as far as quality of life. And I look forward to us continuing that trend and prolonging until we have more definitive therapies to come.
And then the second part of the clinical trial question is, now that there's this conditional approval, I can see a conundrum in a clinical setting where a family wants access to this drug rather than enroll in a trial that the drug company is required by regulatory standards in order to keep that approval.
Yeah.
So how do you balance these two so that on the one hand you provide the care that you want versus the informed consent process of exposing someone? And I don't know whether this is an adaptive trial design or what it is that conditional trial, but I could foresee a lot of problems enrolling in a drug that's available. So is there a way to sort of resolve this conundrum and make sure that we have the science but also the care?
I would like to, that's a really important question. I would like to open the question to our audience experts to make comments or I, as a clinician, I would do everything. I will call the company, I will present the scenario to them, I will give the family the information. They already know. Actually, they come to me, they tell me about this new exciting study, and then I have to go and do research. That's my work. But I do think that it is a dialogue, and I do think that in circumstances, sometimes you could get expanded access to drugs that they are still being tested. Sometimes you don't. So comments, please, from the group.
One of the things that we learned from the cancer research is the importance of consortia,
Yes.
where investigators agree a priori that they are going to prioritize studies so that you can fill the accrual numbers in a timely fashion. Sometimes this does mean overriding the parents' wishes, but it has to be put in the framework of understanding this is the most important way of getting answers that everyone needs.
Yes, indeed.
Hi, I don't have an answer for how any of these trials are going to get filled, especially the post-confirmatory trial, but I will say that PPMD has Duchenne Connect, which is a patient-reported outcomes registry which requires parents and patients to import genetic mutations. And the role of Duchenne, one of the roles of Duchenne Connect is to contact parents and patients when clinical trials become available or are opening that may be appropriate for those children. So one way to get information out to parents is to have all the patients that you see enroll in Duchenne Connect.
That's a great point. Thank you.
Dr. Mah, do you see patients, I guess since that there was a beautiful slide that you showed with regards to the various targets for this treatment. Do you see that patients are eventually going to be on more than one therapy for their treatment? And I guess how will that complicate enrolling in further trials and things like that? Because if you're trying to optimize outcome for a patient, well, then the patient ought to have access to, treatments of different targets.
Yeah, for the purpose of clinical trials, because one drug is being studied, you can appreciate how the sponsors need to focus on one therapy only and not to have a bunch of therapies going. But once we have more and more of these drugs being approved, I am really hoping that we can use a combined approach to optimize treatment for Duchenne, right? We all agree on this. It's just that while we're in the testing phase, it's not possible for us because there could be kind of confounders when you start interacting therapies, and so that's where the difficulty is. Yeah, very good points. Anybody else have any questions or anything? I do have a lot of expertise in the audience, so feel free to please reach out.
Hello, I have a question. I have 2 manifesting females, and they're nonsense.
Yeah.
Does anybody else have any manifesting females? And if so,
And also
do
Becker's.
they treat them? Are they on steroid?
Right. So there is no, as far as I know, again, there is no consensus for use of corticosteroids for Becker or from manifesting carriers, female carriers with the dystrophin mutations. I do have that experience myself, and I discuss with my adult neuromuscular colleagues about what to do in the case of the female carriers. But nonsense mutation, Steve, do you guys have any thoughts?
Yeah, that's a good question, actually. We have a patient in LA that hasn't. Thank you. We have a patient in LA that has, it's a female patient with a nonsense mutation, and unfortunately we couldn't get them into the clinical trial in time, but we are expecting. Do you know what ages they are, actually? 12.
Oh,
Okay.
only 12. Wow, already manifesting.
14, yeah.
Wow, yeah, I am tempted. Like I have Becker that are kind of closer to the Duchenne phenotype. Again, there are no clinical indication for, right? I can't go to any standard of care for Becker, but I have used corticosteroids in that indication. And I think it's a clinical judgment, proper consent to make sure families are aware of the possible side effects of chronic steroid usage. Yeah, definitely. Yeah.
With the preliminary approval of eteplirsen, I'm very interested in how people are considering using it in non-ambulatory patients who are exon 51 skipping amenable, given the limited data in that population.
Yeah, that is part of their ongoing clinical trial. That's now closed. So the advanced stage, and they also have a early Duchenne, like very young boys with Duchenne. So do we have representatives from Sarepta who wish to comment? Because I certainly do have young men too, in the same situation.
Yeah, Dana Martin, Sarepta, great question. In the U.S. we are seeing that physicians are opting to prescribe for a broad range of patients. The label is broad in terms of being able to do that, and I think that was the intent of the trials that we did. We're trying to have the broadest population to be at least have safety data. So I don't know if that helps answer the question, but it is being done.
And I think being in a registry again helps, right? And so it is a way for them to access any updated information. If it is up to me, I don't think I can keep up. But for families, encourage them, empower them, and they will reach out too. And then these dialogues are meaningful because what has been resolved for your family may certainly be beneficial for my families as well.
So just
Right.
from an advocacy perspective as well, I think that Jet Foundation, PPMD, MDA, we have some great resources that we can provide to families and at least experience. So from my experience, again, I haven't practiced nursing on the floor in the unit in 23 years, but it was amazing to me, 9 weeks on drug, I saw a difference in my son. And regardless of what Sarepta's data said, I said, well, is this anecdotal? Am I really seeing this? Maybe it's just wishful thinking. But the fact of the matter is, it goes back to my basic nursing degree, which is you're going to see your, sometimes your most progress in your sickest patients. And so there was a very, I saw some upper arm extremity movement. I saw him moving his feet more. And one of the most amazing things that I saw in my son, who had lost the ability to do this at the age 14, and if you know Duchenne patients, you can appreciate their smile. So Duchenne patients lose the muscles in their face pretty early on. And when you ask your child to smile, and I know this as a mom, I ask him to smile, his eyes will open, but his cheeks, his lips sometimes don't go up. And he really tries hard, and he thinks he's doing it. Well, one day we were getting infusion at the hospital, and there was a nurse there, and she was joking because Jet at that point was 19, 20 years old and just in college. And as she turned, she walked out the door, and she looked at Jet. She said, "Don't be looking at my butt," as I go out the door. It was a joke, but we both turned around, we looked at Jet, and he had a smile that I hadn't seen since he was about 14 years old. So again, whether, considering older patients with this drug and the pristine safety profile that it has, if a parent gets a smile back or a child gets the ability to feed themselves as a freshman in college, those are really important, meaningful things that you need to think about when you're counseling your patients, from our experience.
Thank you.
From the experts, I know that someone already asked this question, but does anyone has any comments to make in regards to the prednisone daily versus weekly, and what age would be the best age to start this treatment?
Hi, I can say that the new care guidelines encourage the use or the initiation of corticosteroids prior to the loss or to the plateau stage. So they're encouraging the use of or the initiation of that medication earlier rather than later.
So I think if you speak to Dr. Connolly and the team, probably 2 to 4 years and weekly? Is that?
I think Anne's study is down to 18, is it 2 years or 18 months?
Yeah,
I think
somewhere
it's
along that
18 months.
border.
So
Yeah.
I would wait for her data, but her study's down to 18 months, I believe, high-dose weekly steroids.
Yeah.
And her broadly, her results have demonstrated similar efficacy with fewer side effects. But again, it's a short-term study in a younger population. So
Yeah.
just watch out for her research.
Yeah.
High dose weekly, high
Yeah.
dose weekend.
Yeah. It's like 10 milligram per kilo.
Yeah.
Times 2. Yeah.
And usually-
Saturday and Sundays with lots of yummy foods to swallow all those pills.
And most parents will do Friday and Saturday, so they only get 1 day of high dose steroids at home.
Okay. All right.
Other questions or comments? No? Well, great. Thank you all so much for coming this morning.
Thank you.
I want to remind you that our team put together a cheat sheet for you. It's at the booth. If you haven't received it, you also got it in your bags. Use it. It'll be downloadable on our website as well. But it's meant to give you an overview of what's going on with all the trials, who's enrolling, what ages, if they're on steroids, ambulatory, non-ambulatory, and we'll update it again in about 6 months. So thank you all.
Thank you. Thank you for sharing your experience.